Welcome to Ground Game, a podcast from the Center for Psychedelic Policy. I'm Sam Chapman, and my guest today is Dr. Adie Rae, a neuroscientist and multidisciplinary researcher at Legacy Research Institute in Portland and co-director of Open, the Open Psychedelic Evaluation Nexus, housed at Oregon Health and Sciences University. She previously served on the Oregon Cannabis Commission and has spent much of her career studying the therapeutic potential of Schedule I substances, including her early work on cannabis and chronic pain. Her team just recently landed a historic $3.3 million grant from the National Institutes of Health to study real-world outcomes from Oregon's Psilocybin program. It's the first time the federal government has funded research into state legal psychedelic programs. We talk about what that means, what Open is, and learning about the safety and health outcomes, why economics of the program matter to researchers, and much more in terms of Oregon's program, where we are, and where we're headed. Hope you enjoy. All right, Adie Rae, thanks so much for joining us on the inaugural first podcast for the Center for Psychedelic Policy. We appreciate you making the time.
Yeah, of course, Sam. Great to be here.
Cool. Well, let's just jump right in. For people who aren't familiar with Open, what is it and why does it exist?
Yeah, so OPEN stands for the Open Psychedelic Evaluation Nexus. It is a nonprofit academic research effort that is housed at Oregon Health and Science University, OHSU, here in Portland, Oregon. The reason we exist is because very early on, during the early days of rulemaking for the Oregon psilocybin program, it became clear that while the state and the OHA, our Oregon Health Authority, were going to create the framework for this program, what they were not prepared or resourced to do was to evaluate the success of the program. So that's where we stepped up a few years ago to fill that gap so that we could really develop a fundamental understanding of how safe, how effective, and how equitably these services were being delivered in the community.
Right. How are we doing so far?
Yeah, we're doing great as a research team. We were fortunate to have a little bit of we were fortunate enough to have a little bit of philanthropic support at the very, very start of our project. That helped us kickstart all of the mechanisms that we needed to be able to start collecting data. Right. And so we, went through a process of defining safety at a time when we didn't have a consensus definition of what psychedelic safety really meant.
Right.
So we did some pioneering work there and published a really important Delphi study that determined what is safety. And then based on that understanding, we developed a custom web-based data collection platform. It is purpose-built by engineers at OHSU specifically for this study, which allows us to have a number of really important, attractive features, which are, it's fully custom. So anytime we need to make an update to it, we can do it almost immediately. It also is highly secure. So, living behind the institutional firewall and having to undergo all of these security tests by the information security departments at OHSU, in addition to having a federal certificate of confidentiality, we're able to build a really robust research platform for this purpose. And all of that investment in building that infrastructure is starting to now pay off. So we've got roughly, 300, I think actually 400, I'll have to double check, clients that are enrolled in our longitudinal study. So the study design is a longitudinal cohort, and it's prospective. So what that means in, everyday terms is we enroll research participants before they have a psilocybin experience, capture some baseline characteristics of how they're feeling, and then we follow them up to a year after they have had their psilocybin experience to track how they're doing over a relatively long period of time. And so that gives us a very clear within-person sense of how their mental health and other symptoms are changing over time.
Right.
So we have a paper that is under review right now, and so when that paper comes out, in the journal proper, then it'll be a real story to talk about with a press release and everything. But what I can tell you prior to that actual peer review process is things are looking really good. All of the things that we are observing in clinical trials do appear to map well onto these community-based psilocybin services. So we do see reductions in depression, we do see reductions in anxiety, we do see reductions in PTSD scores. We also see improvements in life satisfaction and well-being. So we have a lot more work to do and lots of other analyses going on right now. But the long of the short of it is that things are going well. We're, consistently enrolling new participants. We're continuing to have momentum with our grant funding. And most importantly, we're seeing improvements in people's lives.
That's absolutely incredible. And I feel like a lot of people that may exist already in the psychedelic space move right past the importance of qualifying and quantifying safety. Right.
Yeah.
And I think it's really important, especially for those of us who are supporting, work in other states, to not, we can't underemphasize the importance of safety, because that's where a lot of folks get hung up, whether it be stigma or for whatever other reason. Right. And so really exciting to also hear that. And in fact, what you just said, I think, is maybe the first time I've ever heard anyone in your type of position say this, which is that we're starting to see it's not conclusive by any means, but some of this, the similar outcomes and safety metrics that we saw in clinical trials within the state program. That has always been, and arguably is still, a huge question out in the field. So just even though it's early, I mean, what does that early sign mean to you? And what do you think that means for the national movement of, all these states thinking about all these different types of programs? Every single one of them, safety is inherently one of the first questions that comes up. What does that mean so far? I know it's early, but I'm curious.
I'm so glad you're asking this question, Sam. So there's both a light side and a shadow side. So I'm going to start with the shadow side, which is that as much as we would like to have a really diverse population of people who are receiving services, what we're actually finding in our demographics within our research cohort, comparing that to the demographics of the people that are getting services in Oregon broadly, and comparing both of those to the demographics of people who have historically had access to psilocybin clinical trials, these are all the same kind of people.
Interesting, right?
Mostly white, mostly educated, a little more than majority male, but nonetheless, it's not a hugely diverse population of people. The high income thing especially is what is kind of troublesome, right? So these are folks who already probably have other forms of healthcare and mental health care. And so when they have a psilocybin experience, they probably have insurance paying for some kind of therapy that they're, potentially using as a part of their integration. So that's the shadow side, is that, we don't necessarily know how this is going to roll out nationally. We do know that it is matching, these results are matching what we see from the same type of people who are enrolled in clinical trials. So what I would love to see is being able to partner with nonprofit foundations who can provide stipends or scholarships for lower income individuals to receive or pay for the actual cost of services. So once they have their services paid for, then they can be in a position to be really engaged in the research in a way that we haven't been able to see before. But again, that shadow stuff aside, it is really reassuring that we're not seeing, major numbers of challenging experiences, long-lasting, disturbing effects. There have been a handful of very nuanced safety events that we've seen in our data.
Right.
And it continues to be relatively difficult and somewhat subjective to define safety.
Sure.
So for example, like we have our like little box of criteria where we would say, okay, this is an adverse event. But then we also will have a facilitator who will say, oh, the client was nauseous. So it's like, well, is that a safety event, or is that just an anticipated side effect that's unpleasant, right?
Right.
And then we'll have the opposite of that too, where a facilitator will report that this person had to be transported to the hospital. Under the OHA's definition, that is a serious adverse event or a severe behavioral reaction or medical reaction. But when we asked the client, hey, what happened here? They said, oh, yeah, I was really embarrassed about my behavior. Some big feelings came up and I couldn't control myself. But holy cow, my facilitator was super professional and compassionate. I learned a lot from this experience. It is not at all a long-term negative thing in my life. In fact, this is one of the most valuable experiences of my life. Right? And so you have this like nuanced mismatch where you technically have to check a box that yes,
Right.
an adverse event happened, and yet that client perceives it as something meaningful that they can make sense of in their larger landscape of their life. So these are the kinds of nuanced stories and narratives that we're excited to continue to collect, because it will contribute to this larger idea of what does it even mean to have a safe experience or a meaningful experience or a useful or effective experience. And that story is going to continue to unfold over time. We're also really excited to be enhancing the way that we're collecting safety data. So at the time that we went into the field with this study in November of 2024, there weren't any like major field consensus definitions of safety. Right. And since then, the Swiss inventory has come out, and other studies are beginning to use this sort of checklist for, safety events. And that's something that we'll be incorporating in the future, probably starting this summer. So it's exciting to, build on the really important work of other researchers, incorporate their methods into our work so that, we can all collectively be moving toward this really nuanced and rich understanding of safety.
Yeah. Well, and another thing that really stood out on what you said is the individual challenges on face value for a lot of people are things like, dang, we have to check this box. But what I'm really hearing you saying is like, actually, we can look at this a different, the individual challenge is the opportunity for learning. And if we're serious about safety in all of its forms and all of its perspectives, we would be smart to lean into that.
Yeah, I think it's important to collate these objective measures, like right. these observable things, as well as the subjective narrative, right? What does it mean to the person? So if we're only looking at one side of that story, then we have an incomplete picture. And the way that our platform is built, we are able to collate those two data sources for every single psilocybin session. Right. So it's a really unique study design in that way, because we do have this more rich and nuanced understanding.
Right. Yeah. All right. I want to move from safety into outcomes and efficacy a little bit. I think this is another really big question that I'm seeing legislative bodies and advocates grapple with across the country in a lot of different ways. And I think, being here in Oregon, we're incredibly lucky that we, I hesitate to call it a mature program. It's not. Compared to any other program, it is. So in perspective, like, being, 3 years up and running is nothing to sneeze at. I think we're somewhere between 18 and 20,000 people have come to the program so far. The safety record is incredible, like surprising, like to even from some of the advocacy perspectives. It's like, wow, like this regulated system really did what we thought it can do, and hopefully it continues to do that. And I think it will. And a lot of people are really starting to dig in. Okay, how do we measure efficacy? And I think there's a lot of people, myself included, sometimes I want to jump ahead a little bit and say like, okay, well, like what is this efficacy compared to current modalities that states are spending tens of billions of dollars on every year, right? And of course, a lot of people are getting served and being served well. And of course, there's a lot of people who are not, including people who just do not have any type of access to behavioral health care. How are you, from a researcher's perspective, thinking about the efficacy, and how do you quantify or qualify that in the sense of where the program is at right now? Talk to me a little bit more on the setup for looking at efficacy, especially in this program that has a lot of opportunity to grow, but you're doing the work now. So how are you thinking about efficacy within the Oregon program?
Yeah, these are great questions. So there's like a little bit of like I'm gonna like put on the nerd hat for just a
Please.
second, which is like from a like FDA and medical pharmacology, biomedical perspective, the term efficacy means something very specific.
Sure.
And we're usually talking about the efficacy of a drug.
Right.
And in our case, we're not necessarily studying a drug, we're studying a system, right? What is happening in this system? Because in the system, there's a lot of variability from provider to provider, from service center to service center. So we're not actually measuring the efficacy per se, but rather we're measuring the impact of the program. So efficacy trials, when we think about a clinical trial, like that is how you actually genuinely assess the efficacy of psilocybin. And there's kind of like a middle path too, where we could look at a pragmatic trial, which happens inside this, naturalistic community-based environment, but it has a little bit more rigor than just watching what happens over time.
Right.
And so that middle road, that pragmatic trial road, is something we're really interested in, and potentially thinking about putting together another NIH grant for that later this winter. And that would be something very specific. So for a particular population or diagnosis code, that we would very carefully study what happens to people when they get the program versus when they're waitlisted and then they get the program later. So it's a very rigorous design in order to assess the efficacy. Now, we can definitely talk about outcomes, right? Like naturalistic outcomes. And those are the things that we talked about before. So it's interesting, like in the Western paradigm, we often have to quantify things in order for them to be real. So, for example, if we're talking about quantifying depression, there are several depression measures that are used throughout the scientific literature and clinical trials. Right. So we'll use one of those, right? It's 9 questions. So if you have a change on the score in this 9 questions compared to before you got psilocybin and after psilocybin, that's technically a quantifiable outcome. But it's like 9 questions.
Right.
And you've had this fundamentally inexplicable, potentially life-changing, really intense psychological experience that you're trying to shove it all into 9 questions. Right. So, I want to say that, yes, it is exciting that we do have the capability, and we do indeed have all of these quantified measures, well validated, for decades, that have been used in the literature, the PHQ-9, the HADS anxiety scale, the PCL-6 PTSD score, all of that stuff is real. And again, it's an incomplete picture. Right. So, this is where I'm really excited about our work, because it includes some mixed methodology. So we have all these quantified things. We also have the narrative component, where we can do qualitative interviews with our research participants and get them to explain in their own words, how has this experience changed your life, or how are you feeling, Yeah. So that mixed methods approach, where we can have these things that are respected by the academies and policymakers, at the same time respecting people's own subjective experiences. The blending of those methods is really important.
Yeah. And holding that all in one palm feels like it could be like holding water at times. Trying to keep water in your palms, but a righteous homework assignment, if there's ever been one.
For sure. And an honor, at the end of the day, you know this, but your audience probably doesn't know this. Like we both worked in cannabis for a long time,
Right.
and especially with cannabis, it was like, man, it's just there's so much of an industry and there's
Hmm.
so much like stigma and there's still so much like chaos and all of these programs are failing and people are going out of business and people are overdosing and there's just so much going on. And what I always come back to at the end of every day is that this is really about every individual's consciousness, right? What is happening in their mind, in their heart, in their life, their connectedness to everything around them, their families, their deeper being. And so I think that, while I'm extremely proud of the quantitative work that we're doing here, and it is deeply meaningful and it will produce the kind of real world data that will move the field forward. I also want to acknowledge that, this is, at the end of the day, this is about people's hearts and minds.
Yeah. Cognitive liberty.
Yeah.
It's a hot topic right now. I feel like 5 years ago, if you were talking about that, you'd be considered a little woo, but not anymore. Not anymore, at least not in any of my circles. Yeah.
Yeah, things are changing.
Are are and you don't have to pick a winner, but I'm kind of curious based on what you're seeing. And I know it's early. I'm going to say that a lot. I know it's early. But based on what you're seeing so far, is psilocybin, not just psilocybin, I guess, because as you acknowledged before, there's a lot of variables, right? So all of this has, every single statement almost has its own little asterisks or set of asterisks next to it. But I'm curious to ask you the question: is this Oregon psilocybin program or psilocybin, are you seeing it being more effective in some ways than you had anticipated or less effective? And more specifically, like for a certain condition or a certain population? And that could go in either direction, more effective than you thought, or it's less effective than you thought. And of course you can quantify and qualify your answer however you'd like. But I'm really curious, what, based on what you're seeing, where might you be surprised about some of the things that you're seeing, and where might you be surprised that, oh, this is really not what I thought we
Yeah.
would be seeing based on what we might have anticipated? I know from your position you try not to anticipate too much, but I bet
Yeah.
you've thought a little bit about it.
Yeah, I mean, the bummer is that we had anticipated this lack of diversity and
Right.
equitable distribution that we did predict, and unfortunately, that is the case. However,
Yep.
it's a necessary awareness so that we know how much better we need to be doing in terms of equitable delivery across the economic spectrum and racial
Right.
spectrum. So there's that. Is there anything that I'm particularly surprised about? It's pretty early, but the degree of durability that we see between 1 and 3 months, or even 1 week and 3 months, it's pretty stable. So I'm very curious to see what will happen at the 6 month and the 12-month mark.
Right.
In our next studies, one of the things that we're thinking about is following folks for even longer. So doing
Right.
it like a 2 year follow up. So that's a big piece. That's like, no clinical trials really have followed people out for 2 years. So I'd be very curious about that.
Right.
I think that one thing I'm relieved about in our safety data is we have absolutely no one who has reported any kind of boundary violation. So that
Oh,
could even
that's
be
incredible.
something like, like unwanted touch, like this
Right.
person held my hand and I didn't want them to hold my hand. So there's, no sexual contact and no boundary violations in any of our data. And I did just look and confirm we have, just in time for Bicycle Day, 419 people
Love it.
enrolled at baseline. So that's really great news. So yeah, the durability is really interesting. One thing I'm particularly excited about is that, my background comes from studying cannabis for chronic pain. So I snuck in like this really brief little pain questionnaire. It's just three
Oh, love it.
questions. Yeah, and we are finding that in a certain set of people who come in with pain, they have reduced pain.
Right.
And it's strangely not tied to people who have the greatest reduction in depression. And the reason that I bring that up is because the emotional component of pain, the emotional suffering, and the physical component of pain, the body suffering, they're inextricably linked in specific brain areas in our like pain processing regions.
Right.
And so often if we have a treatment that addresses both of those things at the same time, then the person feels a lot better because they're treating two symptoms of the same central nervous system disease that we call pain.
Right.
And so it's interesting to me. I could have sworn that it was only going to be in these people who have, reduced depression that we're also going to see reduced pain. But it's not the case. There's this whole other thing that's happening where, again, this is very preliminary.
Sure.
We have not even submitted this paper to the journal yet, much less gotten our comments back. But the preliminary data suggests that at least for some people, a psilocybin experience can reduce physical pain. Wow. So this is like huge hypothesis generation, right?
Sure.
Like this is like for physical disorders. Well, what kind of pain? Because there are lots of different kinds of pain: cancer pain, non-cancer pain, musculoskeletal pain, neuropathies, and all these different pain syndromes. Which ones respond? Which ones don't? And that's just pain. We're talking about, well, what about other like physical body type things, autoimmune things? Like what else can we reprogram? Right. So I was surprised about the, distinction between the depression and the pain thing, but I'm not necessarily super surprised to see that for some people pain is going down. So that'll be a really fascinating body of work. And I hope that there's at least a handful of people listening to this who are like, yes, I'm going to go and get my PhD and study psilocybin for, pain.
Yeah, totally. That. I mean, it feels like every couple of weeks, a new door has been opened about, the possibilities and the impacts of psilocybin for all kinds of people and conditions. It's not a boring space to be in, people. So you should, if you're thinking about it, you should take Adie's advice here on getting involved in whatever the way that is. All right, this is a fun one. If the legislature said, Adie, we're going to give you $5 million and we want you to pick one behavioral health condition that you think stands to show the best outcomes on, what condition would you pick?
One behavioral health condition. Well, I'm going to cheat a little bit.
Okay.
I'm going to first say that like some part of that $5 million needs to be invested in the program itself.
For sure.
So that the administration of the program isn't just being entirely run on the backs of licensees and their clients.
Adie's been around the block a couple times, folks.
I mean, Sam knows that I served on the Oregon Cannabis Commission in a governor-appointed position for, several years, and we saw this in Oregon's marijuana program as well as other medical programs. Mm-hmm. When you put the fees on the patients, the program suffers and the patients suffer. So let's take some of that $5 million and invest it in the program itself.
Yep.
The other thing that we should do is subsidize services for lower income individuals. Again, this is an equity thing. So some part of that $5 million needs to go toward services provision for low income individuals. If you're on OHP, if you're a veteran, if you are disabled, all of those other social safety network programs that should make you eligible for, low cost, no cost access to psilocybin services. So that leaves me $3 million to work with ish. And believe it or not, I could do a whole heck of a lot with $3 million. What I would like to see most is, and this may be controversial, but my hot take is like, okay, there's enough people out there that are focusing on major depression. It's like, it's kind of like you're searching for a p-value that you're going to find because there's enough preliminary evidence to suggest that it's going to work for
It's a safe bet. It's a safe
bet.
bet.
Right, exactly. It's a very safe bet. Mm-hmm. Similar with PTSD. The jury is a little bit more out with anxiety. Anxiety can be a little bit weird, anxiety
Sure.
disorders. We call it one thing, but it's not one thing.
Mm,
There's lots of different types of anxiety trait and state and different forms of it that have different, mechanisms and underlying, factors. So, those ones are like, okay. But the ones that I'm really interested in are the people who normally get screened out because we're afraid of what to do with them. So
mm,
the folks that I'm thinking about are people with who get diagnosed with bipolar,
mm,
right? And people with psychotic disorders.
right.
So these are like this is probably going to be like a really polarizing topic with some of your listeners because, those are exactly like the high risk kinds of people that like clinical trials want nothing to do with,
Right.
right? And it's specifically these kinds of people who may benefit, but we don't know,
Right.
right?
We
And
need to
so
allow
this
them and
it,
create the container for it. Yeah.
Exactly. And it's in our regs. Like if you're on lithium,
Right.
you're
We
you
took a
don't get to
cautious approach out of the gate for sure.
exactly.
Yeah.
Exactly. And so if we had a very safe environment, very, very thorough preparation, really, really robust system of care,
Right.
and very robust informed consent process. I think that these types of individuals deserve the right
Mm,
to participate in very rigorous, care and research.
right.
It could very well be that this caution that we have around folks with bipolar is unnecessary.
Right.
It could very well be that our caution is indeed warranted, but we will
Right.
never know until we actually collect that data.
Yep.
So thank you for asking that question. It's something I've been thinking about a lot lately.
Yeah. Well, I love it. I don't think that's a hot take at all. Maybe that's not a
Okay.
surprise to you. But like, those people can go buy garbage products that don't have psilocybin in them at all at gas stations, and people are actually dying from those products. So not that that's necessarily the most convincing argument to certain stakeholders, but it's the truth, and
Yeah.
it's worth shining light on for sure. Okay. So I'm going to ask you the other part of that question, which is there a certain condition, and I'm sticking with conditions. I want to put a pin and come back to populations because there's obviously, this is one of the variables that I juggle with all the time in thinking about how do we get more public funding to cover this? How do we move away from the fee-based licensing model that we just copied and pasted from cannabis that's causing all kinds of ruptures at the foundation of the program that maybe we'll have time to get to at some point in this podcast. It might be its own podcast. But what conditions do you think stand to show the highest return on investment from an economic ROI perspective? And I'm not asking you to pretend to be an economist or anything of that nature, but obviously as a researcher, you're focused on a lot of the health related impacts. But if I had to guess,
Yeah.
you're not ignoring economic potential impacts when you're thinking about them. You're still involved in the healthcare system. You still
Yeah.
have a general
Of course.
idea of that behavioral health is expensive, and I think last I checked, the cost of OHP behavioral health services increased 25% in 2023 and went up another 10% just in the last year.
Yeah.
And so I'm curious to get people's opinion on, based on what you've seen, do you have a guess or an educated guess on like where might be a sweet spot for a condition, or what is the condition that might, I'm using all the clarifying words here, produce the highest economic ROI, maybe
Yeah.
when compared to whatever the state might be investing in now outside of the psilocybin program, whether it's talk therapy or prescription drugs or whatever it might be. Which condition do you think might show the highest economic ROI in the state of
All right.
Oregon?
I think I got a good answer for you here, Sam. I think based on the huge, like $5 billion drain on our economy that chronic pain induces, I'm going to go, my money's going to be on people who have chronic pain and comorbid depressive symptoms. So it's not necessarily to say that they need to have been diagnosed with major depression,
Sure.
right? Like major depression is its own thing. Treatment resistant depression is its own thing. And there's lots of, psilocybin work and research that's going in there.
Right.
But if we talk about like, if you were to look outside your window and like count the houses in your neighborhood, like 80% of the people in those houses have experienced severe or chronic pain.
Yeah.
Severe or chronic pain that keeps them from going to work, that requires them to use social safety net systems that the taxpayers all collectively pay for. So like if we're talking about like in general suffering, and we've got this affective mood component that we call depression, we've got this body component that we call chronic pain, that's where my money is, honestly. I think that healthcare systems, like, we could save all these billions of dollars in prescription pain management, all of these other pain interventions, the steroid shots and the behavioral health therapy and ketamine, like just all the things that we're doing, throwing everything in the kitchen sink at pain.
Right.
This is really worth a shot.
And what comes up for me when you talk about pain, you really elevate it this way is, is pain one of those conditions that stands to benefit the most from moving away from treating the symptom and instead treating the root cause? Is that why pain is up there for one of the reasons why pain is up there in your number one category?
It is. And one thing that I've learned from, our prospective cannabis research is that it's not even necessarily about getting rid of or eradicating or turning down the pain. It is about a person's ability to cope with, live with, walk beside the pain, right? So I've seen this come, even as a postdoc, I went to a seminar, I was a brand newly minted PhD in pharmacology doing bench experiments with rats and microscopes and electrodes and the whole shebang. And I go and I listen to this patient and he's on stage and someone asks him, what's your pain, your VAS score, your visual analog, 1 out of 10. He's like, he's an Aussie guy. He's like, I'm about an 8, and he's just sitting there chilling with an 8, just having this conversation on stage. And I'm like, whoa, he had just come off of this 8-week long pain boot camp that was all of these coping strategies and meditation and diet and really integrated novel lifestyle changes. And I'm like, man, what am I doing with pharmacology? It's not about making better drugs. It's about making humans who are more capable of being resilient to their the cards they've been given. So I think that, this is one of those things where, we have evidence that psilocybin can help people reframe their experiences. And if your daily experience is one of intense pain, the ability to crack yourself out of the rut that you're living in with that pain and see everything from a new perspective and develop a new relationship to your circumstances, I think there's a lot of promise there.
Yeah. Well, I don't know if you have Aussie friends or what, but I think you got an 8 out of 10 on the Aussie impersonation score too there. That was pretty good.
I lived there for a long time.
Okay. I could tell. You didn't just pull that one out of your back pocket by any means. I love that.
No.
Oh, that's great. That's great. Okay. So, my one final question there. What is there a one line item of the biggest cost that you think for pain? Is it ER visits? Is it the prescription medication? And it's okay if you don't know. I was just kind of curious. Is there one that just is so much bigger than the rest that is worth highlighting? I hear ER visits a lot when I talk to researchers and doctors in this space. And when I think of pain, I often think of the ER. I'm
not a health economist,
okay,
but
fair enough.
Zooming all the way out, I would say that the number one cost is actually disability. It's the lost productivity. It's the systemic drain on the whole system rather than an individual line item for a particular facet of a person's, healthcare journey. It's, when a person can't work anymore, that's a huge cost to both them and society.
Follow up to that. How I've always envisioned that that stuff is super important and really hard to get to figure the productivity. Has the research field had advancements in being able to drill down on those numbers more? And I'm always thinking about like who the audience is, and like I'm thinking of like a legislator that's going to listen to you for maybe 20 seconds, and so you better be able to just nail it. I'm just kind of curious, like.
Yeah, again, like it's not my area of
Sure.
expertise, but all of these like health economics folks,
Right.
that is their bread and butter, and they have all these really sophisticated models, and I trust them as scientists.
Yeah, totally.
Yeah.
Okay, transitioning gears a little bit. So, well, let me start with a little bit of preface. And this goes off of what you were saying back to kind of the shadow reality of that, out of the gate, we have not yet, let me qualify that, been able to truly make this program equitable and affordable for those who stand to benefit most, right? That's why I'm still here. I took a break for a while and thought about, do I want to come back and keep doing psychedelic policy? And the answer was pretty quickly, yes, there's a job to be finished here. Phase 1, big success. Doesn't get enough credit, to be honest. The fact that we still have a state program, almost 20,000 people have gone through it. Safety is great. Not only no federal intervention, but the feds are actually kicking federal money to do research, what I'm going to get to. I'm going to get to that in a second. I haven't forgotten about that question. But there's going to be a lot of opportunity to figure out how to continue to meet these folks who stand to benefit most, that are in the low income, categories that are disconnected from behavioral health already. I mean, from a research perspective, or maybe just a human perspective, what if you had maybe not a magic wand? I want to stay in reality a little bit here to try and keep it practical and build off of that kind of stuff. But what are the opportunities that come from those challenges? How are you thinking about that right now within the research? How are you thinking about it from a research perspective? If you could just have one or two things change to open that up, and obviously like money is kind of the easy, like just throw money at it, right? To some degree. And obviously you need to do it, tactically, as it were. But I'm kind of curious, like how are conversations of equity and affordability? What are those conversations like in the research field within the psilocybin program space specifically, if we can go that detailed?
Yeah, I mean, we always have to talk about it in terms of a limitation, right?
Right.
Like, there's only so much that you can do with any one of our publications, because one of the main limitations of our study is the lack of diversity in
Right.
the population. So for us, it's a huge research problem that the services aren't affordable. That we would really like to be able to understand at a much more generalizable level how our results are mapping onto the real world. So yeah, I mean the lack of affordability and accessibility creates a bias, or a potential bias, in the data. It could very well be that it's just as good for low income Black people as it is for higher income white people, but we don't yet have enough data to say that for certain.
Right.
So it is a problem for us, because we don't like to talk about that kind of limitation. We would much rather say that yes, this is representative, it is robust. So that's
Right.
a problem for us. Like if I could do things a little bit differently to improve that, one of the things that we're thinking about is, all right, there might be 47 chances to start this over in other states. What could we do in other states as they start to implement their programs? So one of them would be ubiquitous data collection. So it's not just about the people who are opting in to open and deciding to participate in research, that we have all of their outcomes.
Yep.
It could be just like when you go to the emergency department, when you're in the ER, they are collecting data whether you like it or not, because they're using it to improve the quality of their services.
Yeah.
So in the same way, it could be in other states that when you're opting into the program, you are opting into the program understanding itself. And so that way we would know for every single person who went through the program, how is this working for you? So that's missingness. The other thing that we could do is, we could have closer partnerships between the states and researchers. So we're sort of taking baby steps in that direction. Right now, the OHA sends us their, quarterly data, so we get to see it at the same time the public sees it. And we have some degree of the ability to, do some deeper analysis on it. But the problem is the way the data is collected. We don't have the individual stories. We only get the aggregate mean dose, for example, that was administered. So, going forward, it would be nice if we could have all of the raw data instead of just the aggregate data. So we could, do a lot more with raw data. Even one step further, designing the state level, data collection in partnership with state level, administrators. That way, we have actual epidemiologists who are responsible for designing the way that the questions are asked, because they know what the data is going to look like when it comes in. Instead of very well-intentioned public health, officials and agency employees asking questions that, because they're not epidemiologists, they don't know what the data is going to look like when it comes in. So, getting one step closer to high fidelity data that is well designed from a biostatistics standpoint, and then doing that ubiquitously across an entire program. Those are the improvements I would love to see in other states.
I couldn't agree with you more. As one of the people who is made out to be the devil that wanted everyone's data originally with Senate Bill 303, that was not an opt-in. It was intended to be ubiquitous, and for better or for worse, we made compromises, and we have what we have, and it's better than nothing, right? It was still worth briefly celebrating, but I stay up at night thinking about what could have been a little bit too, but I try to move on and think about okay, well, let's make our list and let's figure out, and this is a question for you, because this is the real question, right? There's still plenty of concerns, many of which have probably been lessened because I think a lot of the work that Open has done, especially with the IRB and really being upfront about the importance of protecting people's data, especially in today's world of where very little of your data is protected at all. It's outside of IRB anyways. That seems to be an ironclad type of thing. But what do you say to operators or clients that would be afraid of that, and they say, no, opting in is good enough? Why should I support that? I have concerns in this world in which all my data is already out there. Why should I just fall over and allow that to happen? What's your response to folks that have those kinds of concerns that we've heard in the past?
Yeah, I mean, you're not wrong, right? If you don't want to engage, that is well within your rights. Research is always voluntary. And even when you begin a research study, you have the freedom to withdraw at any time. That's what respect for persons and beneficence and justice means. Those are the pillars that, ethical human research stand upon. And so, you don't want to play, you don't have to. We're not going to win every heart and soul. What I can also say at the same time is that should you choose to participate, here are all of the ways that we're, respecting you and your data. The number one, of course, is that, it is IRB approved, which means the entire research team has to go through this regular training to be able to understand how to conduct human research ethically. That is a very onerous training process. Number two, it means that an outside independent body is watching every move we make to ensure that we are upholding those standards of ethical research. Number three, we go above and beyond that by obtaining a federal certificate of confidentiality. And this is very unique. It does not apply to healthcare data. It's not HIPAA. It is not like the compliance data that is turned over to the state, in the sense that it is not subpoenaable. So no matter what, no conservative lawmaker or no, judge, no anybody for any reason could ever subpoena our data. It is completely isolated from the legal system because we need to respect the privacy of the people who are participating in research. So, if it's not enough for you that we're well trained, we have tight oversight, all of our technology lives behind the OHSU firewall. We have all of these security reviews by security teams at an institutional level, and we have this certificate of confidentiality. If that's still not enough for you to feel comfortable engaging in research, fine, you don't have to.
That's a real world answer right there, folks. I appreciate that.
Yeah.
All right. Open just made some, I think, history, maybe in more than one way, receiving the first ever federal NIH grant awarded to a state legal psilocybin program, or not to the program, but to a research entity based in the state in which the program exists. Tell us about it. What's involved? How many bucks did you get? What is it going to be used for? And I'll repeat this question if you need to, but what does this mean for the entire field? Because I think there's good answers to all those things. I'm sure you have them. So let's hear it.
Yeah, this is indeed a historic event. This is the very first time that the NIH has invested in real world research when it comes to psychedelics. So there have been a number of other grants that have been awarded to folks who are conducting very controlled clinical trials. So for example, Matthew Johnson's stuff with tobacco cessation, that was all funded by NIDA. NIDA is the National Institute on Drug Abuse, who has funded our work. The reason they're interested in our work is similar to, the reason they were interested in Matthew Johnson's work, which is what is the impact of psilocybin services on substance use? And so when we're thinking about substance use, it's very broad. It's, nicotine, cannabis, alcohol, opioids, methamphetamine. It's kind of like all comers. And it's not just for people who have a diagnosed substance use disorder. It's for anyone who wishes to reduce their substance use. So the other really cool thing about this funding is that it allows us to recruit a very rigorous control group of people who are not receiving psilocybin services. So that's the kind of thing that we couldn't ever really do with any other funding source, right? No philanthropist is going to give us, $3 million to go watch a bunch of people who aren't taking psilocybin, right? They're like, that's a waste of money. So that's what's really great is, it will give us this very robust comparison. And this goes back to your earlier question about efficacy. In an efficacy kind of design, you have to have some kind of comparison. Comparing someone to themselves before they got psilocybin is pretty good, but it's not as good as having a whole bunch of people that you compare to a robust control group. So we're really excited about this design. It does, it is a multi-million-dollar grant for 5 years, and it does seem like a lot of money, but boy, howdy, that goes quickly.
It goes fast, people. It goes fast. They're not just sitting on it on a beach drinking, drinks with umbrellas and stuff. It flies.
We have a huge team. There are huge costs to the technology itself, to paying the stipends to the individual research participants, like our biostatisticians and our research associates. And, it takes a huge team effort to make all of this happen. Myself included, a lot of the people on my team, we're putting 80% of our time into this effort, and only 20% of our paycheck is coming from this effort. So don't tell the rest of our grants that we're borrowing and stealing from them to make this work happen. That's always the case in academia.
Sure. Yeah, of course.
But no, it is historic. And I think it's the kind of promising green flag from the NIH that tells us there's something valuable happening here, right? And right now, this initial grant, again, is kind of, I've been sneaking through NIDA's back door my entire career, right? Like the understanding the benefits of a Schedule One substance is not really something they're into.
Sure.
Understanding how these substances impact the use of other more harmful substances. This is how I've, funded my entire career, basically.
Right.
But it's also promising that it seems like other departments within the NIH, not just the National Institute on Drug Abuse, they're also warming to this concept of like, well, all the clinical trials are pointing toward efficacy for major depression, but that's in these clinical trial environments, these really rigorous, like little boxes that few people can fit into, and it's not a really scalable model. Right. So what about this community scalable model? Is it just as effective? So the NIMH, National Institute on Mental Health, is starting to warm up to this idea. So we're hoping that we can make incremental progress with broadening, the interest from lots of different departments within the NIH.
Yeah. Love to hear it. I mean, that cross-pollination and the domino effect is bound to happen. The question is just at what speed, and will it happen soon enough, right? Super exciting, I think. And it's just such a signal to legislators too. I can tell you that for sure. Just the fact that that's been awarded to a state program, it's similar to, when we were running the Measure 109 campaign, when people would be worried about like, isn't the federal government just going to shut this down? It's like, well, we can't technically answer that question. They have not. And if they were going to, I would have assumed it would have happened 2 years ago. We would tell them, it's like, look, is psilocybin illegal at the federal level? Yes. Have several federal agencies also given like more than just a warm yellow light, but like a screaming green light saying psilocybin actually is a breakthrough, a designated breakthrough. It's been designated a breakthrough therapy option, and has real potential above and beyond current available options. And if that doesn't show the hypocrisy of psilocybin being a Schedule One, I don't know what does. So anyways, I think it falls in that category, except it's, the first example was like chapter 1. We're in like chapter 7 of a infinite chaptered book at this point. But
You know what, though, Sam? You bring up such a great point in that, in some of the qualitative work that we've been doing, we interview various stakeholders like mental health care providers and people who provide harm reduction services, drug checking, stuff like that.
Right.
And out there in the wild, there is a lot of confusion about what is even legal. People in California think that they can just like go and get psilocybin from their normal therapist, and it's like, what? That's not a thing, you know? And so like, I think that, especially with cannabis, it's just so glaringly obvious, and it's been going on for so long, this mismatch between federal policy and state level practices, that people just don't even care or pay attention to what is federally legal anymore. Yep. It's weird though, because then for other populations, like we've been working with some first responders who are going through psilocybin retreats, and they're like, oh, no, I am not participating in research because I can't afford to have my name in some database somewhere.
Yes.
I don't care about your federal certificate of confidentiality, Adie. I'm a firefighter. I'm not going near you. Right. And so like, it's this weird, like, it's obviously federal drug policy reform is long overdue. Yeah. And it would change a lot of things, like the ability to do banking and not have to do all these weird shell LLCs to evade 280E tax stuff, like wouldn't it be nice if this was just like your average acupuncture clinic?
Right. Yep.
That's where I'm going for here. Like, can we just make this like a garden variety alternative medicine market?
Right. Is the acupuncturists that also have like their own self-governing board of licensees? Is that, do you know that?
I don't know. It wouldn't surprise me.
Okay.
A lot of those professional associations have that kind of thing. Right. Which is great.
I foreshadow some things for future guests that are interested in major overhauls of the program that might help open up some more blue sky. But we'll save that one for another time, folks. All right. Well, we're coming up at the hour here. Final question. What's the single most useful thing someone listening to this podcast could do to support you or Open's work right now?
Yes, great question. So you can visit our website, openpsychedelicscience.org. And if you are a facilitator, whether you're licensed or not, you are covered under our IRB protocol and our certificate of confidentiality.
Oh, wow, that's news to me. I didn't know that.
Yes.
I knew that you had talked to people generally that were across the entire spectrum, but that's incredible. That's a real
Yep.
function of law that I really enjoy.
Yeah, so legacy or above ground, you are invited to participate as a facilitator. Once you're enrolled as a facilitator, you're also a research participant, so your time is compensated every time you fill out a survey. You get a gift card,
Yeah.
and it's really through the facilitators that our clients gain access to this research program. So facilitators, please, visit our website. You can also email openstudy@ohsu.edu, and that will get you straight to our research assistant, Kelly, who's amazing, who can help you get onboarded to the platform. It's very easy to use, and we, even provide compensated coaching calls to help you be successful. If you are a client interested in psilocybin services and you'd like to participate in research, you can also go to our website and find a number of participating service centers. And then we can do a little bit of matchmaking to get you with a facilitator. If you already have a facilitator that you have in mind and they're not on the platform yet, feel free to share the website or the email with them.
Incredible. And we'll make sure to have all these links and stuff in the show notes as well. But just to put a little bit of emphasis on, I think, something that a lot of people overlook, especially people who don't know, they're curious, they've heard about psilocybin, but they don't know much. These kind of, quasi matchmaking services that are being offered here are incredible, right? Everyone is coming to this from a different place, from a different background. We're all different people that need different types of support. And the matchmaking really does an incredible job and is a heavy lift to do on your own, especially if you're starting from ground zero in terms of looking at this. So take Adie and the Open team up on that offer if you're interested. More info in the show notes. And Adie, thank you so much. Really appreciate you coming on. This has been great. We'll need to do this again sometime soon.
Such a pleasure, Sam. It's always great to talk with you, and I'm really happy that you're doing this effort. I think it's going to make a big impact.
Oh, thanks so much. All right. Talk soon.
All right, thanks.